I would be talking on this topic of adults and PCOS. Basically, why I choose about the adults and PCOS, a lot of things are talked about the adult ones, the Rotterdam criteria, which I don't want to repeat again. I want to focus on the basic things in adolescence where we start correcting this weight gain, the obesity, and the other problems right from the womb and immediate postnatal period. Immediate postnatal period, if you put on a lot of weight, excessive diet to the baby, leading to obesity, especially in an IUGR baby, land up in a lot of complications of obesity, the metabolic syndromes, and diabetes in particular. Polycystic ovaries is the most common cause of infertility in women, frequently becomes manifest during adolescence. That's the reason we are focusing on adolescence, characterized basically by hyperandrogenism. The diagnosis of PCO has lifelong implications, especially the metabolic syndromes. And PCO should be considered in any adolescent girl with chief complaint of hirsutism, treatment-resistant acne, menstrual irregularity, and obesity. A lot of work has been done on this. The collaborative effort initiated by the various international bodies, about 12 bodies, international bodies sat together and discussed about the issues of pathophysiology, diagnosis, and treatment of adults and PCOS. Hence, I'm going to talk on these three factors. Why we need to know pathophysiology is, unless we know the basic causes, the pathophysiology, the genetics, the genes which are affected by the epigenetics. The etiological factors, it can be a congenital or postnatal. This, I want to focus on the postnatal provocative hit, where insulin resistance, the postnatal obesity resulting in these conditions. Coming to the pathophysiology, the androgen excess observed in nearly 60 to 80% of the people, of patients with PCOS, which is a key disorder in adolescence. The pathophysiology basically starts with ovarian abnormality. The insulin resistance and hyperinsulinemia is seen in adolescents, but it's not a prerequisite for the diagnosis of adolescent PCO. The endocrine alterations, the genetics, and more important is the epigenetics, which control genetics and alters sympathetic nerve activity. This is the pathophysiology where I'm focusing on basically the ovary and steroidogenesis, how these are altered with genes affecting these structures and epigenetics altering the genes. The intra-ovarian leptin, cytokines, and the oxidative stress is the one where we need to focus on. This is the minimal model of PCO pathophysiology. If you understand, it starts from the pituitary level, LH, FSH. FSH ratio is important. Previously, we would say it's not so, but ratio is important in adults and PCOS. And hyperinsulinism and the insulin resistance develop, which lead to functional ovarian hyperandrogenism. 95% of the cases is the functional ovarian hyperandrogenism, and 5% it's only the functional adrenal hyperandrogenism, even in PCOS. And the other factor which affects the luteinized sex steroids and the polycystic morphology of the ovary. And this polycystic morphology is not a requisite for diagnosis of adolescent PCOS, since in adolescence, most of the people who come to us, young girls, 13, 14 years, they say it's menstrual irregularity. Most of the time, we try to convince them saying it's a HPO axis abnormality, which sets right after 2 years of menarche. But most of the practitioners, they send it for ultrasound and they find a PCO picture, which is an exaggeration of puberty. So don't consider it as an abnormal one and start treating such cases. And the primary ovarian pathology, where it focuses on the growing primordial follicle, and all these are affected by the dynamic balance between these hormones from the pituitary to the ovary. In PCO, the balance between the androgens, anti-Mullerian hormone, and FSH is disrupted, leading to the follicular arrest. This follicular arrest leading to high LH, and hence the insulin resistance and hyperandrogenism. AMH secreted by the granulosa cells play a major role in governing this balance and inhibits the transition from primordial to the primary follicle. If we know this about the importance of primary follicles, we can start treating them. As I told you, insulin resistance is there in adolescents, but it's not a diagnostic factor. I'm going to come up to that. And the neuroendocrine alterations, where I want to focus on the LH levels, the LH-FS ratio, elevated LH pulse frequency, and decreased FSH levels leading to inhibited follicular growth. And altered kisspeptin signaling in the PCO is the current one which we need to focus on, and the altered GABA signaling and PCOS. The other metabolic modifiers which we know about is AMH, insulin, and the adiponectin. Coming to the diagnosis part, these are the various things how we start about in diagnosis of an adolescent PCO. That is, the detailed history and the physical examination is important. Screening tests for the causes of abnormal cycles, screening tests for abnormal hyperandrogenism is important in these cases to know whether the hyperandrogenism is a functional ovarian hyperandrogenism or from the other organs. Then endocrine screening panel, we try to rule out the other causes. Additional evaluation of PCOS patients is important. And evaluation of the family members in these adolescent girls is very important because most of them, it's a genetic environment which you see in these mothers, sisters, and who they go in for metabolic syndromes in the other family members. The metabolic syndromes have to be screened. Hence the importance of screening the family members. What are the indications for evaluation? All cases of PCOS don't evaluate. You should know in which case you want to evaluate. Unless you have these three symptoms of degree of hirsutism, focal hirsutism with menstrual abnormality and menstrual abnormalities. So you're concentrating on only two things, menstrual abnormality and hyperinsulinism, hirsutism, sorry. There are four phenotypes. The phenotype type 2, hyperandrogenic anovulation, is a type of PCO you see in adolescents. The International Consensus Diagnostic Criteria of Polycystic Ovaries in Adolescents in 2015 was, this is how they started with focusing on the adolescents, and they said it's only the abnormal uterine bleeding and evidence of hyperandrogenism in various levels. Moderate to severe hyperandrogenism should be there for diagnosis because mild hyperandrogenism is nothing but an exaggeration of puberty, as we all know. So don't start treating hyperandrogenism in young girls unless it's moderate to severe. And what is moderate severe, we'll talk about. This is the International Consensus Consortium update focusing on all these factors. And here, if you see, the required ones in the criteria is irregular menses or oligomenorrhea, evidence of hyperandrogenism, be it biochemical or clinical. And other features like PCOM is not a prerequisite for diagnosis, even the obesity, hyperinsulinism, and other biomarkers. This is one chart where I want to project here. I'm short of time, I can't read the whole thing, but if you have the chart, you'll know after 1 year, how many days, how many cycles are important in a year, and finally, in coming to beyond 6 years of menarche, it is minimum of 9 cycles in a year which is required. There are 13 cycles in a year, at least 9 cycles if they're there, it's considered normal, below which you say it is abnormal. This is the evaluation of a hyperandrogenism. We are concentrating on the FSH-LH ratios and the total testosterone. You can't do free testosterone. All labs will not do it. So we can go about with the total testosterone and ask them to evaluate the free testosterone. Functional gonadal hyperandrogenism and functional adrenal hyperandrogenism is seen in adolescent groups, 5% functional adrenal hyperandrogenism. There are two variants, the typical PCOS and atypical PCOS. Atypical PCOS is the one where you see, apart from the functional ovarian hyperandrogenism, even the adrenal hyperandrogenism is there. That's the place where we need to correct it. The calculation, the 9 areas are taken, and each area is given a score of 1 to 4, and a score above 8 is considered abnormal. The same thing for acne scoring, mild, moderate, and severe. Moderate to severe is considered abnormal in an adolescent. Coming to the ultrasonography, this is important since polycystic ovarian morphology is commonly seen in an adolescent girl. It's an exaggeration of puberty. So the ultrasound, the person who's doing an ultrasound should know what is the age of the girl on whom they are doing, what are the number of follicles, and what's the ovarian volume to say it is abnormal. Either it is 12, up to 12 in both the ovaries, or a single ovarian volume up to 14 to 15 ml should be there to say it's a polycystic ovarian morphology. And number of follicles are also beyond 12. Before evaluating a case of hyperandrogenism and polycystic ovaries, you have to stop COCs, minimum of 2 to 3 cycles before evaluating these cases, because the symptoms and the diagnostic values are altered in these women if you give COC and then do the test. This is about the recommendations, 2000 fertility sterility, which they gave about in detail about the PCOS. As late as August, this is August 2018, fertility sterility. Coming to the management of it, treatment, 3 things you have to concentrate: the abnormal uterine bleeding and hyperandrogenism, and in the process you have to correct obesity. So focus on obesity so that the other 2 also get corrected. Main treatment is COCs, then COC which have too hard. Desogestrel doesn't control androgens, but the other 2 have your ciptoteron acetate and rosperidone are very important combinations as anti-androgens. You have to take give the OCs with these combinations, and you can give metformin to control insulin resistance and obesity.